Okay, thank you very much. These are my financial disclosures. None of them are pertinent to this talk. So there's lots of ways of doing capsule management. There's all of these manual CCC, vitrectorrhexis, Ertley, Zepto, the new capsulase, femtosecond. We're all agreed we're not doing can openers in children. They're not helpful. They don't get the lens in a good place. But I'm also going to talk about the two-incision push-pull rhexis. The two-incision push-pull rhexis was devised by myself, gosh, many, many years ago, because I didn't want my learning curve to affect a child's outcome. So the idea was that you make two stabs. The distance between the two stabs is the opening of your anterior capsule. And so we've published quite a lot on this technique. This is how you do it in a child who's young, under the age of about 4. The older they get, you have to do it in stages, and I'll show you those. So this is a 5-month-old, if I remember correctly. You use the calipers just to give you a rough idea. I normally put them at 4.5. I use a 6 millimeter diameter optic. So by the time you finish doing the opening, it's normally about 5 millimeters. So you make 2 stabs. You have to use an MVR blade. And I wonder if I can show this to you. Yes, okay. So you've got 1 stab here, and you've got 1 stab there. Now, the thing is, when you do your distal stabs, you've got to remain in 2 planes. If you push back, you end up with a V, and that becomes a problem. All I'm doing here is I am pushing forwards the proximal stab, and then I stop. You can see the tear is forming like a perfect semicircle, and then I pull. Now, the reason why this happens is that the child's capsule is very elastic, and it's very difficult to flatten completely the anterior curvature. So those 2 facts allow you to create what essentially is a perfect rhexis. Now, if it's a young child like this, that's it. The 2 meet. They often don't meet identically, so you have to tidy it up, which is what I'm doing here. If the child is older, like I would say over the age of about 4, you have to make sure that your tears include the initial stabs so that there's no weak point. Now, what you'll see in a minute is me doing the aspiration so that you can see what the rhexis looks like. And as Aditya was saying, I always take the peripheral lens matter out first in case there's a defect. Now, obviously here there was no defect, but what I believe is that you should do in the easy cases what you need to do in the difficult ones. So when you do it in the difficult ones, it's second nature. Now, when I do the posterior rhexis, and I'll tell you when I do that, in fact, very similar to what Dr. Vasavada was saying, I go in obliquely, again with the MVR blade, and this is where the 2-incision push-pull rhexis really becomes, in its own kind of space, because when I have fellows come, this is the first rhexis they do, is in the posterior rhexis. And the reason is, and again, I'm doing what was described, I'm expanding Berger space. When you push and you pull, you're not worried about the tear going out into it can't, because the vector force is always in the middle. And so it's a very safe way of learning how to do a posterior rhexis when you've never done one before. And all I'm doing is pushing and pulling. And I'm going to show more of this in a minute, but I'm just showing you that for a second. So when they get a bit older, you end up with 2 stabs, but you take 1 side each. So you start here, and you start here, you stop, you pull this, but as you come round, you include your initial tear so that there is no weak point. That's just a sort of a, now I hope this is working. Oh, it says cannot play media. Oh, good. All right, not to worry, let's see what we have here. So this is what we're trying to avoid, right? We are trying to avoid iris optic capture. And you have to make sure that the opening of your anterior capsule is smaller than your diameter of your optic. And the problem with children is that it might all look very nice at the end of the operation, but children rub their eyes. And when they rub, they trampoline the anterior chamber. And that's when the optic can come forward if your anterior opening is bigger than the optic. So what you're aiming for is this. So what I want to show you here is, this is immediately at the bottom here, is immediately after taking out the lens matter, how the posterior capsule bulges forward. And this is after you've put visco in, how it goes backwards. But this bulge, you have to be aware that that is the case because of positive vitreous pressure that you see in children. So in my hands, I mean, there are lots of papers that have been published. I tend to do a primary posteriorrhexis in all cases, even up to the age of 18, but only with an anterior vitrectomy if they're 4 or under. So if they're 4 or under, I'll always do an anterior vitrectomy. Anybody above that, I just go ahead and do a posteriorrhexis. And the reason why I do that is people say you can do YAG laser capsulotomy on the older children, but they're not like adult capsules. And they often have lens epithelial cells that have grown, and so you try to do the capsulotomy and you can't get through cleanly. So I just prefer to do the posteriorrhexis, and I've shown you how I do that. I use a heavy viscoelastic. I tend to use Helon 5 because we can't get Helon GV at the moment in the United States for whatever reason. But I agree, I think Helon GV is better than Helon 5 for most pediatric cases. So I really, okay. You know what? I asked you to check that these were working. AV, can you play the video directly? Because I gave you the videos. I loaded them up. Just play it directly. It should be in the file that I gave you. There we go. Try the posterior capsule. Play that for me. Doesn't matter how much time you spend with AV. Okay, so this is a posterior plaque. And this is where, again, the 2-incision push-pull really is very helpful, because you make the 2 stabs either side of the posterior plaque. And now when you push and you pull, the edge of the plaque is the template. So I'm pushing back the visco. So these are the more complicated cases, right? And I just grab the plaque and I just pull. Push. And the tear is happening right at the edge of the plaque. Now, people worry if your posterior opening is big, but you don't need to worry. Once you inflate the bag, and I always use a 3-piece lens, the haptic goes in and it goes just underneath your anterior capsule, and you open the optic in the anterior chamber. Now you just knock the optic into the bag, and then you place the leading haptic with a McPherson's. You don't rotate. And that way you can safely get the lens in. See, I'm a little bit surprised at aren't you, that they can play the video. For some reason they can't play it from the PowerPoint. I'm not sure what's going on, but never mind, that's fine. Okay, if you stop that for a minute, please. Can you stop that, AV, please? Okay, so can you play where it says PX3153, not that one? That one? Go ahead. Okay, all right, don't worry. Go back to the PowerPoint. I spent 2 hours with these guys at the AV on Thursday, but never mind. All right, can you just show me? Thank you. I'm sorry about this, folks. It doesn't look like I'm going to be able to show you this, but I've shown you one. So this posterior fibrous plaque technique was also repeatable, done by Dr. Kesawani, showing that it works very well. So it is a good one. This is the one that we just showed you. Probably this one will play. Good. All right. So I like to use the integrated intraoperative OCT for the intumescent cataracts. And what you can see here, I don't know if you can we turn down the lights? You can see that here there is a lake of fluid. So you see where these dark areas are? That's where the fluid is. So what I do is I go in with a needle aspirating on a cannula or on syringe and I stab that dark area and suck out the fluid. That way, you can stop an Argentinian flag occurring, but obviously I use Helon 5, and that's what I've done here. I've made the little stab, and you see here, unfortunately, I don't know if you can see it. Can we switch off the lights? No. Okay, don't worry. So what you see here is that it's been decompressed. Okay, I really hope this is playing. All right. This is a case of aniridia, all right? What I want you to notice, if I just pause that, look at the capsule. The capsule in aniridia may not be normal because PAC6, which is the gene that is mutated in aniridia, is expressed in lens epithelial cells. And the lens capsule is thought to be the basement membrane that is secreted by the lens epithelial cells. And I want you to notice that this here is not how a normal capsule looks like. It's got breaks in it. And that's something that I recognize now, because when you do an anterior opening in these, sometimes, very occasionally, they can split because they're not robust. However, the posterior capsule in aniridia is always robust. So what I'm doing here, I cannot risk having the lens come forward because it's aniridia. So now I'm going to do a posterior optic capture. Now, when I do a posterior optic capture, I always do an anterior vitrectomy. I know some people don't, but in this case, my worry was that if I didn't do a vitrectomy and there was pressure, I might tear the capsule. And so I wanted the least amount of pressure. Again, I'm putting in viscoelastic. And I've made 2 stabs, one here and one here. My time is up. Tough. That's AV's fault, not mine. And you're going to grab the 2 stabs, 1 stab at a time. I'm going to push and pull. Now, if you don't have the micro Capsulorrhexis forceps, borrow the membrane peeling forceps that your vitreoretinal surgeons use. They're just as effective. And I'm just doing a push and a pull. I've only got about a minute left at the other. Now again, if you're doing a push and a pull and you know that you're going to do an optic capture, then what I do is I'm using that second stab as my guide. So I do a continuous Capsulorrhexis, but it becomes my guide for the size that I want. So you don't have to do the push and the pull completely. You can modify the technique depending on what you're going to do. So in here, I'm like, okay, I'm going to have to do a posterior optic capture. So to give myself that extra reassurance, I'm going to do a continuous curvilinear, but I'm using that second stab as a guide as to how long I need to make it. So for the sake of time, how long have we got left on there? Yeah, it's about a minute. Is that all right, Aditya? Okay. So now I'm doing I've put the lens in. It's a 3-piece. And like everybody's shown, you do a rocking maneuver and you rock the anterior first, the leading, and then push back on the trailing, and that's the kind of almond shape that you want. Okay, thank you very much indeed. And if anybody wants to join Icon, please do take a picture of that QR code.
Thank you so much for that very interesting presentation. And most of your surgeries had most of us having our hearts in our mouth, and you did it so